my name's Sheruni. I'm also a rehab physician working in the Northern Adelaide Health Network at Modbury Hospital in Adelaide. Will's already given a lovely introduction to our service. Thank you for having me. I'm going to be speaking on the topic of rehabilitation of dysphagia. And dysphagia obviously is difficulty swallowing. Any disruption to the complex, coordinated, voluntary, and involuntary process of swallowing will result in dysphagia. It's quite a large topic in itself because there are many causes and therefore specific treatments. But I'm going to try and give a general overview and some general principles that will be relevant to you all and hopefully helpful. In rehabilitation, we will occasionally see undifferentiated cases, but largely we will receive patients into our care. The cause for the dysphagia is known, so I'm not going to spend too much time on diagnosis. I'll cover some epidemiology, anatomy and physiology of normal swallowing, and look at etiology, assessment, management, and prognosis. So it's a relatively common problem. Day to day, we see multiple patients with dysphagia in our service, and I'm sure you all do as well. Worldwide, 590 million people are affected by dysphagia, and there's an estimated worldwide prevalence of 8%. Worldwide, obviously, the population is aging. By 2050, we'll have sort of 30% of the developed world will be over the age of 60. 10 to 30% are likely to have dysphagia. There's a high economic burden. Dysphagic patients in hospital often are in hospital for longer, and the treatment they require may cost more. And obviously, we have to consider the psychosocial impact on the individual and the family. There's many significant complications of dysphagia: aspiration, pneumonia, sepsis, malnutrition, dehydration, social isolation, impact on social well-being, depression is very common, and increased carer burden, and obviously death. There's a threefold increased risk of death within the 30 days following a diagnosis of aspiration pneumonia. So that speaks to the significance of, appropriate management of patients with dysphagia. Just to cover very briefly the anatomy, just to get you familiar, this is the oral cavity. You've got the soft palate here. You've got the three parts of the pharynx, the epiglottis, the esophagus here at the back, the larynx leading into the trachea. And then radiologically, you'll see similar structures. You can see here the epiglottis, again, the hyoid bone, and important structures to be aware of on imaging: the vallecular space and the piriform sinus, which we'll touch on later. There are a multitude of muscles involved, supplied by cranial nerves 5, 7, 9, 10, and 12. It's a complex, coordinated function of these muscles that leads to effective swallowing. So there's 4 phases of swallowing, which we'll go over now very briefly. The oral preparatory phase, this is under voluntary control, and this is when the patient takes food or fluid into the oral cavity. Saliva helps to moisten the contents, which is manipulated. There's mastication, bolus formation. The tongue is crucial in controlling the movement of that bolus to the back of the oral cavity and preventing premature falling of that bolus into the pharynx. Then you get to the oral propulsive phase, where again the tongue is compressed, so the bolus is moved towards the oropharynx, and this is what triggers the pharyngeal phase of swallowing. And so this is the pharyngeal phase. The images depict this. It's a reflex phase. It's under neuromuscular control. Essentially, you get raising of the soft palate to block off the nasopharynx. You get anterior and elevation of the hyoid or the laryngohyoid complex. Subsequently, the epiglottis moves downwards to cover the trachea, and you get pharyngeal constriction, increased pressure in the pharynx, upper esophageal sphincter relaxation, which moves the bolus down into the esophagus, leading to the esophageal phase, which is essentially peristalsis in the esophagus, moving the bolus down towards the stomach. And then the larynx moves back into its anatomical position once that's all complete. I'll just briefly play this slide. This is just a video of normal swallowing. You can see the bolus in white. Take note of what happens to the soft palate and the epiglottis closing over the trachea and the bolus moving through safely. So we'll move on to causes, and I'm going to divide this into causes of oropharyngeal dysphagia versus esophageal. So oropharyngeal dysphagia causes can be divided into neurological disorders, stroke, structural lesions, psychiatric disorders, connective tissue disease, and iatrogenic causes. So this table's from Bradham. We commonly see, certainly in my practice, a lot of patients post-stroke with dysphagia. Generally speaking, hemorrhagic strokes have a high incidence of dysphagia than ischemic stroke. Posterior circulation infarcts are more associated with pharyngeal phase dysfunction, and therefore you're more likely to see aspiration and penetration. Purely anterior circulation strokes, generally speaking, are associated with more oral phase dysfunction. And this table just shows sort of the prevalence in some of those etiologies. So cancer of the head and neck, sort of 50% will be affected. Motor neuron disease at the time of death, 81% will be affected. I'm not sure about this number here under stroke, but from my other readings and what I've seen is around 50% of stroke patients will be affected by dysphagia. Then the causes of esophageal dysphagia can be divided into mechanical obstruction and motility problems like achalasia or systemic sclerosis. And just a quick note that aging will result in dysphagia, so that is also a common problem that we see. There are anatomical changes which are sort of briefly outlined here. You get increase in residue overall, and generally it takes more time for everything to happen, for the whole process of swallowing to occur. So you just need to be wary in elderly patients that, dysphagia can be a problem. So signs and symptoms, there are the obvious ones: choking on food, coughing during meals, drooling, loss of food from the mouth, but also consider the patient that has had a dramatic change to their diet, weight loss, malnutrition. You may see patients with esophageal dysphagia with reflux and heartburn as a presenting complaint. And you may also sort of come across patients that have had change to their vocal quality as well. Just want to go through a few definitions. So the definition for penetration in the context of dysphagia management is when there's entry of food or fluid into the larynx, but not below the level of the vocal cords. Now, this is normal in everyone, in healthy individuals, but the healthy individual has a strong cough and a strong ability to clear their throat and move that material out of the larynx back into the pharyngeal space and down through to the esophagus. So it's when we come across a patient with penetration who has a weak cough and an inability to clear their throat that we need to get worried. That takes us to the definition for aspiration. So this is entry of material below the level of the vocal cords. Brainstem strokes and people that have a weak cough, recurrent lower respiratory tract infections, abnormal chest x-rays, you'll probably suspect aspiration in, and there's increased risk in those who are immunologically compromised, have chronic lung disease, poor oral hygiene. And then there's the silent aspirator, which is essentially the patient that aspirates but has no awareness of this. They show no outward sign of difficulty. They don't initiate cough or any attempt to rectify the aspiration. So assessment, essentially, it depends on what your encounter is with the patient. I'm going to take it from the point of view that we already have a diagnosis, and now we're in the process of assessing the patient to form some recommendations and develop a rehabilitation plan. So at the bedside, we will sort of perform a neurological examination, including an oromotor examination, which we'll talk about on the next slide briefly. Always view inside the mouth. Do they have xerostomia? What is their level of saliva production? Is there any other pathology, thrush that can be easily treated, any visible obstructions? Observe their swallowing of a variety of food and fluids, and see what their responses are. Speech pathologists often use cervical auscultation to determine at the bedside if there's any evidence of aspiration or penetration of food whilst they're observing swallowing. Also at the bedside, you can view, is the patient swallowing saliva spontaneously? Is there a spontaneous cough reflex, or is that absent? So the oromotor exam is essentially quite simple, just referring to the thorough cranial nerve examination of 5, 7, 9, 10, and 12, which are involved in swallowing, and I alluded to earlier. In terms of investigations, we won't spend a lot of time here. We need to make a decision about whether we perform further investigations to that which is needed to make the diagnosis. So investigations to help plan the rehab and further assess risk. So we might consider, intracranial imaging, chest x-ray to look for signs of infection, manometry, pH monitoring to help determine cause, particularly if we're thinking about esophageal cause of dysphagia. Upper GI endoscopy is a similar concept. Barium swallows to show us the sort of structure of the esophagus. But I'm going to spend most of the time talking about the modified barium swallow and the functional endoscopic evaluation of swallow, or the FEES test. So the modified barium swallow, or MBS, is used interchangeably with the term video fluoroscopic swallowing study, which you may see abbreviated as VFSS. For this study, the patient needs to be sitting comfortably. They're given a variety of food and drinks of varying textures and thickness, and this is mixed with a radio-opaque substance, barium. Then radiographic images and videos are taken, which gives really valuable information. The test should be done jointly with a physician and a speech pathologist. And the main thing here is that the test should be observed. You need to observe how the patient responds to the varying textures and thicknesses of the food and fluid. Do they cough? When do they cough? Are they able to throat clear? And how does that correspond to what you're seeing on the image? What is their respiratory rate? Generally, in normal healthy individuals, swallowing doesn't interfere with the normal rhythm of respiration, but in a dysphagic patient, you may see prolonged apneic times as they're trying to initiate the swallow and finish that process. Following a prolonged apneic period, the patient often will take a big breath in and a big gasp for air, and that's when you might, have particles moving into the trachea and causing penetration and aspiration. So it's really important to view the patient during this study. The other thing we look at is movement of the anatomical structures, particularly the hyolaryngeal complex. We want to see that it's elevating and moving anteriorly. That's normal. Dysphagic patients often don't show that movement appropriately. These are just some static views. So this is a patient who's swallowing a puree bolus. There's no evidence of penetration or aspiration, where we would see sort of a dark line coming anteriorly here. But following the swallow, you can see that there is a significant amount of residue in the vallecular space and in the piriform sinus. So we don't want to see that. So that's residue that really shouldn't be there. This is a video. Again, person is swallowing fluid, and you can see here most of it travels down into the esophagus, but you're starting to see some penetration, and then you can see it flowing through here, causing aspiration. And then this particular video actually shows the barium. In a minute, you'll see it traveling into the lungs. So this patient's overtly aspirating. This is another patient, a lady having a sandwich. Seems to move through nicely into the esophagus, but again, there's a significant amount of residue left in the piriform sinus and in the vallecular space there. Same patient is given a chaser of water, and you can see they do a double swallow with the water, and the residue is completely gone essentially, and it's disappeared, and the water's traveled down into the esophagus appropriately. So the last two slides just speak to the fact that the barium can help guide the advice you give a patient. So in this case, this lady was probably told, you can have a degree of solid food with small sips of water in between, because the barium showed that that residue could be moved effectively with a sip of water. So the MBS is in comparison to the investigation called the FEES, which you can see a static picture of here on the left. It does give a bird's eye view of the pharynx, so it's quite a different view to what you'll see with the MBS, and the scope enters via the nose. The issue with this particular study is that during the sort of crucial reflex swallow period, you get complete whiteout. You don't see anything. The video doesn't capture anything. You just basically get a screen of white. So you don't get any effective information of what's happening to the swallowing structures during that reflex phase. It can really be useful though. You can view the movement of the vocal cords. You can look for residue after swallow. So it still does have a role in dysphagia rehabilitation. It doesn't require any radiation it doesn't expose the patient to any radiation, and it can be done at the bedside. So the patient doesn't need to go anywhere else for it, unlike the MBS, which the patient needs to be taken down to the radiology department, often seated on a very narrow chair. So they need to have good trunk control, good sitting balance, in order to perform that. The MBS, however, does expose the patient to a low level of radiation. So we'll move on to sort of principles of management. The aims are to maintain nutrition and hydration, reduce risk of aspiration, and to really maximize the patient's quality of life. And we do all of this in a multidisciplinary setting, as you all know. So it's really important to recognize that all of these roles are important. We need our nurses to be able to implement the dietary recommendations that are given. We need the dietitian to assess, the nutritional status of the patient. Are they getting enough protein in their diet? OTs, we need to help with upper limb function, for example, to help the patient feed themselves. The physio, we need to work on sort of trunk control and, endurance, so that the patient can sit for the appropriate amount of time upright in order to eat safely. And obviously the speech pathologist is crucial also. So I'm going to talk about modified diet, modified fluid regimes. Maintaining oral hygiene is extremely important. We'll talk about that. Treating oral health problems. We'll talk briefly about enteral feeding where it's required, and then we'll touch on compensatory strategies, rehabilitative exercises, and some other treatments that are beginning to be used, as well as, reviewing of medications. So these are sort of what I thought were the big important groups of things to consider. I'll just start with review of medications because it's quite simple. What I'm talking about here is reviewing the patient's medication list. Are they able to swallow the tablets? If tablets are recommended to be crushed, can that particular tablet be crushed, or does it have to be changed to something else? So that's really important. And the other thing is, are they on any medicines that are going to affect their swallowing? So in particular, thinking about medications that may contribute to dry mouth, anticholinergics, antidepressants. And then also thinking about medications that might be making the patient drowsy and fatigued. So reviewing opioids, benzodiazepines, and sort of really fine tuning the medications to maximize the, you know, recovery of the dysphagia, and also to reduce the risks that dysphagia poses. So the IDDSI has, provided this really great framework. It's freely available online, so I urge you to have a look at it if you haven't already. It consists of a continuum of 8 levels, so 0 to 7, where drinks are measured from 0 to 4 and foods are measured from level 3 to 7. So it provides a common terminology to describe food textures and drink thicknesses. The website also has a lot of information to give clinicians and family members and patients on how to prepare the foods to match each IDDSI level. So that's really, really useful, I think, to be aware of. Practically speaking, if you have a patient that needs, thickened fluids, for example, there are thickened powder sachets readily available. This is just giving some idea of cost. Here on the right, it is in Australian dollars. But these are all available on Amazon as well, and quite cheaply, so quite easily available to patients. Similarly, you can get pre-packaged thickened fluids. Costs are there on the right again. So they are quite expensive, but they're available as well. Juices, cordials, but also desserts, snacks. And in the case of a patient that needs a high energy, high protein diet, they also come in a protein supplement forms as well. And interestingly, the powder thickeners you can add to basically any fluid, including, alcohol. If a patient wants a glass of wine or a beer, you can thicken that with the sachet powders. So as the patient's swallowing function improves, we need to think about whether their diet can be advanced to the next level. Soft or semi-solid fluids and the consistency. So you just need to think about whether they're tolerating the current regime, get collateral from carers, from the nurses. Are they able to maintain a safe position to upgrade? Are they medically well? Also think about where they are. Are they in a hospital? Are they in a nursing home? Are they, at home alone with no support? And consider that in your decision making. Also consider the patient's preference, patient satisfaction, and what are their goals, their personal goals? What is it that they want? And obviously also, what is their hydration and nutrition status? Are they dehydrated and malnourished? Does something need to change in their diet? So always being in touch with the dietitian, the speech pathologist, to get that constant feedback about where the patient is at with regards to those things. Oral hygiene is really, really important. It should be performed a minimum of 2 times a day. It should be done with a wet mouth swab to clean the oral cavity. If you are going to, if the patient does want to brush their teeth, if they're severely dysphagic, you probably have to do it with suction. Otherwise, you can use a dry toothbrush just to scrub the teeth and then rub some toothpaste over the teeth. There are alcohol-free moisturizing sprays, mouthwashes and gels that can be used to help with sort of saliva management. Poor oral hygiene is associated with poor outcomes and increased risk of aspiration. So we really need to address that. Always, treat thrush, any other oral conditions a patient might have. It's really important to treat those. And if a patient usually wears dentures, make sure that they have their dentures with them at the bedside. I'll touch on free water protocols. This is for a select subset of patients where they're allowed to have small sips of water despite their dysphagia in order to maintain hydration and improve quality of life. The key here is that oral care is paramount. They must have very good oral care. The sips of water cannot be during meals and can only start a minimum of 30 minutes after the meal to make sure that all food residue has been cleared. Start with very small volumes, just teaspoon amounts, maximum up to a cup size of water. They cannot use the free water protocol to swallow medications. It's not part of the protocol. And it's crucial to have the family and carers involved for education. It's a good protocol. It's been shown to improve fluid intake, improve quality of life, and hasn't been shown to have any adverse effects. But I have listed some inclusion/exclusion criteria here. You need to choose the patient appropriately. Low risk feeding strategies, I'm just going to touch on very briefly. We, come across carers, family members that want to feed the patient because they feel that's what they need to do. But this puts the patient at increased risk of aspiration. So we really need to encourage self-feeding, and the families need to be educated about that. The other thing is just to consider the patient's position, upright, calm environment, supervise so that the patient doesn't eat too quickly. If you're going to use equipment to help with the swallow, so certain types of cups, straws, just make sure that they are appropriate for the patient's swallow function. So, if they may only need a small stream of water to come through the cup, and you might need to sort of use a cup that allows that to happen. And always observe for signs of problems for up to 30 minutes after feeding. I'll just touch on non-oral feeding here. It may be required in some patients to meet nutritional goals safely. Not everyone is going to require it. I think it's important to know that stroke patients may start off with a nasogastric tube, but usually it can be removed as the swallowing improves. I think it's something like around 10% of stroke patients will require sort of a PEG tube feeding at the 6-month mark post-stroke. And in degenerative conditions, particularly motor neuron disease, just always be aware of the fact that they will require PEG feeding down the line, but the insertion of that PEG or RIG tube should be done early before the forced vital capacity drops below 50%, because if it drops below the risk of inserting a PEG or a RIG is a lot higher. So you kind of need to preempt the onset of their dysphagia. So treatment exercises, simple things like thermal and tactile stimulation with an extra large jumbo cotton swab, just rubbing the lingual palate to stimulate sensation and to try and initiate a swallow in a patient that can't initiate their own swallow is very, very useful. So actually triggering swallow, like swallowing, is actually a really useful exercise for patients with dysphagia. Range of motion exercises for the mouth, lips, and jaw, the speech pathologist can also prescribe. There are a range of treatment exercises that can be prescribed to the patient. Supraglottic swallow is one of them. Quite simply, ask the patient to take a breath in, hold their breath, swallow, and then cough out as strongly as possible. The supraglottic swallow is a variation of this. There are lots of handouts available that you can use to give your patients to educate them on these exercises. Effortful swallow is essentially a normal swallow, but you ask them to squeeze very hard with their tongue and throat during the swallow. And that's essentially a strengthening exercise, as is the Mendelssohn's exercise, where they actually physically try to lift the larynx and the neck muscles upwards following the swallowing action, and hold that position for up to 3 seconds. Again, there are videos of these online that you can have a look at. The Masako is done, the patient holds their tongue in between their front teeth and swallows. It's quite a simple one. And the Shakers, which is essentially a chin tuck against resistance. The transcutaneous electrical nerve stimulation is, it's not something that we're using in Australia, but I understand that it is being used overseas. It's essentially peripheral stimulation of the oropharyngeal muscles. And I have seen a case of this, a young Indian man. He was about 9 months post-stroke. He had quite significant dysphagia. He went through a long period of swallow rehab here in Adelaide without a huge amount of improvement, and then travelled back to India to visit his family, and during that time received TENS therapy, and actually returned, and the MBS showed complete resolution of his dysphagia, which was quite remarkable. So there's a lot of research ongoing into this. Very briefly, there's also transcranial direct current stimulation, which is, again, there's a lot of studies, some systematic reviews, but it's weak evidence. I think the studies have significant limitations, and the studies aren't necessarily comparable because there's no protocol for the duration or the frequency or anything like that. So it's quite varied, the protocols. So further studies required in this area. Similarly, transcranial magnetic stimulation, there's very limited studies looking at its use in dysphagia, but there are studies ongoing. Compensatory strategies, I'm almost at the end. These are strategies that basically they're not going to necessarily improve the patient's dysphagia, but will allow the patient to swallow safely and compensate for their impairment. So we've talked about this throughout the talk. Maintaining an upright posture is very important. Using the chin tuck technique to facilitate forward motion of the larynx and thereby prevents food from entering the larynx. We typically tell patients to look over their weak side or head tilt to the weak side, which essentially guides the bolus through to the unaffected side of the pharynx. Supraglottic swallow, which I talked about a few slides back, is also used as a compensatory strategy. A double swallow and a cough is also very effective, and you saw that in one of the videos I showed earlier. She double swallowed, drank some water, and cleared her residue quite well. And very important is supervision for cueing patients, particularly if you've got an impulsive patient post-stroke. It's very important to have someone supervising and making sure they're not eating too quickly. Obviously, everything we've spoken about, please, consider within the ICF framework. I haven't talked too much about the psychosocial implications of dysphagia, but they can be quite profound, and also the impact that it has on the carer. The carer that has to feed the patient at each meal, the carer that has to, put together the net feeds, for example. It can be quite a burden. So we need to, keep all of that in mind and manage those situations appropriately. Prognosis is difficult to comment on because, in a general sense anyway, because there are so many causes, but specific to stroke, just so you're aware, about 50% will have dysphagia as a result of their stroke. Most cases resolve within a week. A smaller percentage will remain dysphagic at 6 months post-stroke and require a form of non-oral feeding. And older age, prior dysphagia and brainstem strokes, particularly lateral medullary syndrome, will confer a poorer prognosis. My references. Thank you for listening. If there's any questions,
thank you so
my
much.
email at the bottom if you have any questions or you want to look at any of the slides.
Thank you so much, ma'am, for a wonderful session. It was very informative about swallowing and dysphagia rehabilitation. Any questions from the audience? No questions? Ma'am, I want to ask a question. Ma'am, can you please elaborate about cervical auscultation? What to expect? What are the maybe positive findings in normal and in stroke patients?
Yeah, so I think, look, I'm not really, I don't do this in practice, but I know a lot of speech pathologists do use it. And before this presentation, I was speaking to a speech pathologist who said this is probably one of the only things that they can do at the bedside that might give an indication of, the fact that a patient is silently aspirating. So I think basically you auscultate in the cervical region, and you're listening to see if there's any sort of uh, breath sounds, but that change from before the swallowing to after the swallowing, if that makes sense.